Hey guys, what's up? This is Stephanie. Welcome back to my channel. So in the video today, I'm going to be discussing my 9th month in a physician assistant residency / fellowship in critical care medicine. So the reason why I use the names interchangeably is because they are interchangeably. Depends what program you apply to. They might call it a residency or they might call it a fellowship. Regardless, it's the same. Just depends what specialty you go into. So I'm going to go into critical care medicine. That's what I'm doing right now. And just real quick, a little bit about me. I am currently a physician assistant. This is my ninth month in a critical care medicine residency. Definitely, by far, I'm very happy that I decided to do this residency because I've learned so much since the first day I started the residency, and it just kind of makes you marketable as a physician assistant, and you're very well-rounded versus trained on the job. So if you're trained on the job, usually they will just train you for whatever ICU you are doing. Versus me, I was able to rotate through several critical care medicine departments. So my residency is going to be 1 year, it's 12 months, and so far the rotations I've completed have been the following. So I did the first month in surgical trauma ICU. Surgical trauma, usually the patients that we see, like it sounds, are going to be any type of trauma patients, so your motor vehicle accidents where they suffer severe orthopedic injuries where they require surgery. In addition to that, any type of gunshot wound to the abdomen, for example, and also any type of injury to, for example, the abdomen, like I discussed. So other examples of abdominal injuries would be patients that had an embolism or thrombus in any type of their arteries that perfuse their intestines or bowels, for example, where they required surgeries where they need to get some of their colon removed. So a lot of these patients have drains very everywhere, so it's during that rotation you get really familiar with these drains and just identifying a normal one versus an abnormal, whatever is on the drain. So these are the type of patients that we see during surgical trauma. My second rotation was in neurotrauma ICU, so a lot of the patients that we see there are any type of spinal cord injury. For example, we think about motor vehicle accidents. Once again, your hyperflexion, hyperextension, your patients that dive in forward and unfortunately have any type of cervical fracture and get paralyzed, very, very sad, especially in the younger patients. Any type of head trauma, also traumatic brain injuries are the patients that we see here. And then my third month was in the neurovascular ICU. A lot of stroke patients, That's the majority of the patients that we see. We see a lot of subarachnoid bleeds, head bleeds, for example, your epidural hematomas, your subdural hematomas, any type of disease that causes paralysis like Guillain-Barré syndrome, right? I even had a patient that had West Nile virus. That one was really interesting. And then also any type of post-neurosurgery patient. So patients that have like pinealomas that are removed, that need monitoring, etc. And then my fourth month was in surgical ICU. So most of these patients that were in the surgical ICU were patients that had any type of, for example, thoracic surgery. So we think about our patients that have like VATS, any type of patient that had any esophageal also surgery, so any type of esophageal removal, if they had a history of esophageal cancer, Roux-en-Y, gastric bypass, etc. And then my fifth month was in the cardiothoracic ICU, definitely by far one of my favorite rotations. Just like it sounds, any type of cardiac patient, so patients that have any type of mitral valve repair, aortic valve repair, your post-CABG, so post coronary artery bypass grafts, for example, cardiac transplants, heart transplants, lung transplants, etc. And then my sixth rotation was in the medical ICU. Unfortunately, when I did that rotation, it was during the winter and I saw a lot of COVID patients, so I got really familiar with ARDS and just ventilator settings. And then my seventh month was in the transplant ICU. Just like it sounds, transplant patients, your liver transplants, kidney transplants, even small bowel transplants, pancreas transplants, which were very rare, and then also got really familiar with treating GI bleeds, whether they were upper or lower, and then cirrhotic patients, since that was the majority of patients that we saw there. And then my eighth rotation was back again in the surgical trauma ICU, and I do have to say I learned a lot more the second time I came around because I knew a lot more in comparison to the first time, which I was literally a fish above water because I didn't know what was going on or how to treat the patients. I was not even familiar with the ventilator. I felt every question that the nurse was asking me, they were trying to pick me. But now I feel a lot more comfortable. And now I just completed the neurovascular ICU, and that's my second time around. And given my second time around, I'm still learning new things every day. I felt like I learned a lot already the first time when I rotated, which was my third rotation, but now I'm on my second time going through there, and I've learned a lot more. But I do have to say that now I feel a lot more comfortable with just everything. So now what I'm doing is that I'm working overnights with an APP, so an advanced practice provider, whether it's a nurse practitioner or PA, and they let me run the floors. So this ICU that I'm in has 22 beds, and I run both of the floors. I'm the only APP from 6 p.m. to 6 a.m. So any new admission that comes in, I admit them. If they need to be lined, I line them. If they need to be intubated, I intubate them. If the patient's actively crashing, then I have to treat him, etc. So I'm running the floors by myself. Of course, it's nice to have that cushion. If I have a question, which happens multiple times, that I have a question, they're able to help you. But in essence, you run the whole floor. And I think that's really big because you're able to run codes if a patient's actively coding, etc. So now that's what I'm doing. And I do have to say that I feel a lot more comfortable in comparison to the previous times where I didn't feel comfortable overnight. I feel a lot more comfortable. I feel more comfortable with ventilators, being able to change ventilator settings, weaning off patients off the ventilator, actually, and even having to take that step from going from a BiPAP to intubating the patient, or even a patient that's hypoxic and taking that step of placing them on BiPAP and then having to place them on the ventilator. What medications are you going to use for a patient that's going to be on the ventilator, right? What are the doses? Like, are you going to use, for example, rocuronium, which is going to be your paralytic, right? Etomidate, etc. What are going to be the doses depending on how much the patient weighs? How are you going to intubate them? Are you going to use a glidoscope, or are you just going to do direct laryngoscopy and intubate them, your DL, right? So that's another thing that I feel a lot more comfortable now. I do have to say that video laryngoscopy is definitely my favorite because you're able to see in your camera what you're looking at. And then also usually your supervising physician feels comfortable also because they're at the bedside and they're able to look at what you're looking at. And so I feel a lot more comfortable with intubations. I think I have about 11 under my belt that I've done. I am actually going to go in a few weeks with anesthesia, and I'll be doing intubations the entire time I'm there. So I'll just be intubating patients. So, and of course, all they use is DL. They don't use video laryngoscopy. So we'll see how that goes, since I don't really feel comfortable with DL. But you know what? I need to feel comfortable, because if you have a patient that's actively crashing and you don't have video laryngoscopy, then you need to know how to use a DL. So I'm very excited about that. I'm very familiar now with vasopressors, which I really like now. So I'm able to know when I'm going to use norepinephrine versus epinephrine. When do I need to add that second vasopressor, right? And which second vasopressor am I going to add? Also, what is the characteristics of each one? What are the mechanisms of action? What do they do? On what type of patients do I use them on? If a patient's going into shock, what type of shock is it? Is it septic? Is it cardiogenic? Is it hypovolemic, right? Being able to go through each one of these. If the patient's being hypoxic, having your differential diagnosis, right? Is this patient hypoxic because they have PE, which is very, very common in patients that I see in the neuro ICU or neurotrauma, because most of these patients are paralyzed or have some type of trauma to their brain where they're actively not there. And so that's one of the things that I really like, that I felt like I've learned so much. But I think I kind of have the critical care medicine a little bit down. What I don't have down is neuro. So I definitely need a lot more teaching, and I need to learn more about neurology just in general. And so I'm really excited because my residency has geared the rest of my residency, since I completed all the core required rotations for the residency. Now the remainder of my residency is going to be just based in neuro. So I'll be going with neurology, with the stroke team, and I'll be actively going and seeing the stroke patient that's coming in, being able to make those decisions on whether this patient needs some type of interventional, do they actually require it or not, etc. I'll be spending time with neurosurgery in the operating room with the surgeries that they do. And then I'll also be spending time with the post-cardiac arrest team, which I'm really excited about. PCAS is what we call them. So since a lot of the patients that we see are post-cardiac arrest also, I really like that because it's all about temperature management, EEGs, and I just love it. So I'm really excited that I'm going to spend time with them. I'm going to spend time with neurointerventional team, and then also radiology, since I'm very familiar and comfortable reading CT, abdomen, and pelvis scan, CT chest. I'm comfortable with reading chest x-rays, abdominal x-rays, but I'm not comfortable with reading MRIs. I can tell on a CT brain or a CT head if there's like midline shift, or if there's an active hemorrhage, or like they teach you in PA school, right? That convex sign, that concave sign to tell the difference between an epidural, subdural, hematomas. But those are the basics, but going more into detail, I definitely need more learning, especially with your MRIs and the different types of MRIs that there are, and which ones you use to rule out a stroke versus a mass. So I'm very excited that I'm going to be spending time with radiology in regards to learning how to read these, because most of these patients, especially in the neurovascular ICU, you want to watch out for herniation. So if a patient has a change in the neurological exam, definitely you have to send them to the scanner, and you need to know how to read that CT scan or identify if there's been a change from their previous scan, rather than waiting for a radiologist to read that scan for you. So I'm really excited about that. And then during this rotation, definitely feel more comfortable with my neuro exams. My neuro exams were terrible, but now I'm a lot more comfortable with my neurological exam. So I have to say that I have grown as a provider a lot more from the first day that I started the residency until now. For the multiple reasons that I discussed, I'm able to line a patient that's actively crashing versus struggling trying to find the artery or the vein. I feel a lot more comfortable with the point of care ultrasound, which is becoming part of the physical exam for critical care patients. If I have a patient that I'm not sure if I want to diurese them because they're fluid overloaded or not, and my physical exam doesn't tell me a lot because they're not edematous, I can come around and grab my point of care ultrasound, look at their heart, look at their IVC, and look at their IVC. Is it flattened or not with the respirations? How does their heart look? Is it, for example, fast? Is it slow? I've been able to see Takotsuba's cardiomyopathy on an ultrasound, etc. And then not only that, also looking at the lungs with the ultrasound, the difference between B lines and A lines, right? Whenever we see B lines, which looks like comets on your ultrasound, tells you that the patient's fluid overloaded. So that can help you on top of your physical exam, on top of your BMP, to make decisions to diurese this patient or not because you think they're overloaded. So I feel more comfortable with my POCUS, my point of care ultrasound, in regards to cardiac, in regards to pulmonary, in regards to looking at the arteries and veins for placing central lines in the neck, for example. I do have to work more on arterial lines, and I do have to say sometimes if I have a patient that's very, very thin, or they're older, or they're just very hypovolemic, like fluid down, it's really hard for me to get that line because the artery is like super small. And so it's really frustrating to me, and there's been times where I go and I cry because I'm like, I can't get this line. It's really frustrating. I feel like I'm a failure, but I know it's going to take time, especially if I have one of the senior PAs come in and just like puts it in within 5 minutes, and it took me 40 minutes to try to put it, and I still didn't put it in. So, but I just have to know that I'm learning, and I'm very hard on myself. But yeah, that's everything I've learned. I'm so excited. My next rotation is going to be in the Trauma ICU, so I'll be back there again. I'm terrified because that rotation is just very hard. So we'll see how it goes, and I will give you guys an update. But just in general, as you can see, I think I've grown as a provider, and I feel a little bit more confident every day versus the first day I started. During my presentations, whenever I was giving my plan, I would always ask the doctor or my attending, is this okay? And this is what I want to do. And what do you think? And now I'm like, this is what I want to do. This is what I do. And this is what I want to do because of this reason. And this, and this, and this, and this, and this. And so I feel a lot more comfortable. All right, guys, I hope this video is helpful. As always, if you have any questions, feel free to comment below. I will try to get back to you as soon as I can. Unfortunately, my residency is just super busy, so it'll be a little hard, but I will get back to you. All right, guys, I'll talk to you later. Bye.